Hi everyone. This is the next in line. This is the theory and looking at resistance exercise and training. There are three sets of slides here. I think what I'm going to do is it was kinesiology and then it was stretching. I'm going to do this first because there's some proprioceptors I have to talk about within muscle tissue, and then we'll move into the PNF because you need to understand the proprioceptors before you can understand PNF exercising. So when we look at resistance training, it's basically resistance exercise, and this is muscle performance. So when we look at muscle performance, we talk about what is the capacity of a muscle to do work, whatever that work may be. So the equation is force times distance. So you have a force, you need to apply a counter force in order to do that, to move something from one to another. Performance can be affected by morphological qualities of the muscle. So how the muscle itself looks. Is it big or small? This is why, certain times you can't perform something because you're not strong enough. It could be because maybe you haven't got enough muscle bulk there to be able to create the tension that's required. Neurological, biochemical, and biomechanical influences. So the nervous system's not speaking well to the muscle, or the exchange of chemicals within the muscle isn't working properly, or the joint's not functioning properly, all this is going to have an influence, as well as metabolic, cardiovascular, respiratory, cognitive, and emotional function. All these things can affect muscle performance. When we look at resistance exercise or training, we have three things that we look at. It's either strength training, power training, or endurance training, or any combination thereof. So the question I have for you to ask yourself here, after I ask it and pause for a moment, is what can cause muscle weakness? What is it that can result in a muscle being weak? We're going to get back to this later on, but maybe pause it, take a moment, and write down what you think can cause a weak muscle. So when we look at resistance exercise, we say that it is any form of active exercise in which a dynamic or static muscle contraction is resisted by an outside force applied manually or mechanically. That could be a weight machine, that could be a dumbbell, or it could be you as the therapist applying resistance as the patient actively moves. So what is strength? Basically, we know that when a muscle shortens, it creates tension. And the tension it creates places that tension on the tendon. The tendon is attached to a bone on the other side of the joint, and the increased tension brings one bone into a different position. So the muscle has created enough tension to move that bone from one place to another. If we have a hand and we place a 25-pound weight on that hand, then in order to move that 25-pound weight, the muscle needs to create enough tension to meet the resistance of that 25-pound weight to move it from one position to another. So strength is the ability of a muscle to produce tension and a resultant force based on the demands placed on the muscle. So that can be a weight, could be an implement, a tool that we use, it could be moving something, it could be doing anything. It is the greatest measurable force that can be exerted by a muscle or muscle group to overcome resistance during a single maximum effort. So if we're trying to measure someone's true strength, what we do is called a 1RM, and we ask the individual to do a maximum 1 repetition movement, whatever that movement is. Say, let's use a chest press. So we ask a patient to perform a maximal bench press, a weight that they can only do one time. We then take that one time contraction, and if we are working with them, we then take that one time contraction and we look at the percentages of it in terms of what we're asking the patient to do. So they could be doing 70% of the weight or 50% of the weight or 30% of the weight. Functional strength, on the other hand, is the ability of the neuromuscular system to produce, reduce, or control forces contemplated or imposed during functional activities in a smooth, coordinated manner. So if we go back to the kinesiology lectures, and I had that slides on the kinesiological analysis of what's happening, you can see here that when we're looking at functional strength and we're thinking of, how does the muscle function, what joints, what kind of contraction, and so forth. The other part of that was why do we need to improve strength, and what is the task at hand that needs to be done by the patient, whatever that may be. And we'll get into that a bit deeper as we go along. Strength training then is the developing and increasing of the muscle's ability to produce stronger and stronger tension. So development of muscle strength is an integral component of most rehab or conditioning programs. This is all ages and all abilities. Anybody can train. Anybody can adapt. And we're going to get into adaptation a bit further on, but understand that all ages and all abilities can be strength trained to some degree. Strength training is a symptomatic procedure of a muscle or muscle group lifting, lowering, or controlling heavy loads for a low number of repetitions over a short period of time. So when we are looking at strength training, we are applying a fairly heavy resistance with a low number of repetitions up till 8, between 4 and 8, and a very short period of time. When we do this through adaptation, we get an increase in muscle strength. So we're going to learn something here coming up about Wolff's Law, but ultimately what we're doing is we're stressing the muscle out and forcing it to adapt to the new work it needs to do. And again, a little more time is going to be spent on that a bit later. So that's strength training. The second one I mentioned was power training. Strength is high weights done in a very short period of time. Power is related to the strength and speed of movement and is defined as the work, force times distance, that we saw when we were looking at strength, produced by a muscle per unit of time. So power involves strength and time. In other words, it is the rate of performing work. So this can be done over a brief period, so an explosive movement to lift the box up onto a high shelf, or it could be repeated bursts of less intense activity, such as climbing a flight of stairs or doing something consistently all the time, some kind of movement. So if we're looking at power as being strength over time, how do we power train? Well, due to the many explosive functional movements required day to day in our life, reestablishing muscle power may be a priority in a resistance prescription. So if we've got a patient who's come to us and they're doing something, say, as bursts of less intense activity over periods of time, we may be wanting to train the patient to do those things as part of their power training or their power changes in terms of the adaptations phase. So how can we do this? Either by increasing the work a muscle must perform during a specified period of time, or reducing the amount of time required to produce a given force. So let's say, for example, the patient is, they have to move something that's 5 pounds 30 times an hour. If their strength is only they can get to 5 pounds, that means that we're asking the patient to work maximally a lot. What we want to do is we want to power train that patient so that they could maybe maximum do 10 pounds. Now, because they can do 10 pounds rather than 5, their job that they're expected to do at the 5 pounds means they're only working at 50% of their max. So their perception of work becomes easier and the chance of injury goes down considerably. So these are the things you need to think about. This is why we look at these various types of training. The greater the intensity of the exercise and the shorter the time period taken to generate force, the greater the muscle power is. Let me repeat. The greater the intensity of exercise and the shorter the time period taken to generate the force, the greater is the muscle power. For example, there's a form of training called plyometric training. If you've been to a fairly modern gym, we actually have jumping platforms now, where you place the platform in front of you and you go from a standing position on the floor and you jump up onto the platform. This is explosive power. You're providing an amount of tension or strength explosively in a very quick period of time to jump up onto this platform. So the more intense, the harder I have to jump to get higher, then the greater muscle power I require. Okay? The third type of training is muscle endurance training. This is having a muscle contract and lift or lower a light load for many repetitions or sustain a muscle contraction for an extended period of time. Generally, these are low intensity movements. A a large number of repetitions in a prolonged period of time. An example could be something that I see relatively common now is a cashier in a grocery store who is wearing a wrist splint. So it could be that, if we go back to this 5 pounds and working at max, it could be that this cashier needs to get those forearm muscles stronger because of the work she does, and is less likely to run into needing a splint due to problems. So she or he, when they're doing the cashier work, not a heavy weight, but doing the same movement many, many times over. When we put a patient on an endurance prescription for strength, we are trying to increase the muscle's oxidative and metabolic capacities. So if you've done the Krebs cycle, you had an A&P, we're talking about improving the system of using oxygen to create ATP and basically meet a greater metabolic need of the muscle as it's getting more and more, shall we say, in shape with endurance. Quite often, we start with endurance training if someone has had something significantly done. So post-orthopedic surgery of some kind or other, the patient's relatively weak, the joint's been affected or the muscle tissue's been affected. We would always start off with endurance work long before we ever started strength or power work. So I've sort of alluded to this adaptation stress. For a muscle performance to improve, a load that exceeds the metabolic capacity of the muscle is applied. The muscle must be challenged to perform at a level greater than that to which it is accustomed. This is known as the overload principle. This is stress and adaptation. What in essence I'm doing is I am stressing the muscle out by applying a fairly large load. And because the muscle is being stressed, the body will adopt and make the changes within the muscle to meet the need of that weight. Okay, so the muscle must be challenged to perform at a level greater than that to which it's accustomed. If it remains the same after adaptation, there's no further increases. So if I start a training program with a patient and I don't increase the weights, they're not going to be increasing their strength. You constantly need to be overloading or stressing the muscle out for it to adapt. So how do we do this? We either increase the intensity, the resistance, or how heavy the object is, or the volume of exercise, either more repetitions, so doing the exercise 4 times versus 8 versus 10 versus 12, and how many sets of frequency they do it. So maybe we start out, they do 1 set of 8, then they do 2 sets of 8, then 3 sets of 8, then 1 set of 12, and so forth. So we either do this by increasing the resistance or increasing the repetitions or sets of frequency. When we do this, the question becomes, how do you determine what it is? Well, obviously part of it is understanding what the patient's requirements are in terms of maybe their job or whatever they do. So this is always applied in the context of the underlying pathology, age of the patient, stage of tissue healing, fatigue, and the overall abilities and goals of the patient. So we always keep in mind, what pathologies has the patient got? How is it affecting what they can or cannot do? How old is the patient? If they're quite elderly, maybe their ability to have to be able to last a long period of time is compromised. Stage of tissue healing. So obviously, I may not want to be putting heavy weights on tissue that's still in the process of healing, and so forth. The other thing we want to do is something called the SAID principle. This is specific, adaptation, imposed demands. In other words, it is a framework of specificity that is a necessary foundation on which exercise programs should be built. So this is the idea that when you sit down with your patient, you ask what kind of functional things they're required to do. You then take that and compare it to the condition at hand in front of you, whatever limitation the patient has. And then through that understanding of the requirements of the work they need to do and the problem they have, you try to create an exercise program that eventually becomes extremely specific to the demand that they need to make. Remember, we have to have adaptation, and we have to apply a stress that allows the muscle to adapt and become stronger. This is known as Wolff's Law. Body systems adapt over time to the stresses placed on them. So we have to remember, if you don't continue stressing it, you will not get any change. So part and parcel of strength training is constantly stressing or overloading the muscle in order for it to adapt and become stronger. So when we talk about the specificity of training, well, the adaptive effects of training are highly specific to the training method. So depending on whether it's strength, power, or endurance, whatever you apply, that's what you're going to affect in the body systems of adaptation. If it's strength, they're going to get stronger. If it's power, they're going to get more powerful. If it's endurance, they're going to gain more endurance. In other words, exercises incorporated into a program should mimic the anticipated function. So that's one thing you need to think about is when you start looking at a sport that they play or a job that they do, this has to start driving your prescription in terms of what you're after. So is it strength, power, or endurance? What muscles are required to perform the task? Whatever that may be. How often do they have to do it, and so forth. So this specificity should also be considered with respect to the type and velocity as well as the joint angle. It's not unusual for therapists to actually have their patient pretend in front of you what their job is, how they bend, how they turn, what they're expected to do. You need to get right down to trying to figure out exercises that mimic those movements as close as possible, as long as it's in a safe way. Regardless of the simplicity or complexity to be learned, task-specific practice always must be emphasized. So this is something you need to think about from a rehab perspective again. What is required of the patient and how can you train them specificity-wise in order to get them more functional to the work that they're doing. What I would like you to do here now, this was group working under normal circumstances, but unfortunately we're not in groups right now. So what I would like you to do for this week is I'd like you to go through this assignment, the small assignment that normally is done in class, and I'd like it done by Friday. And if you could, place your prescription in the discussion board so we can have conversations around it and move forward. So please stop the slide for now. Go through this slide and come up with a 3-month treatment plan for this individual based on some of the things we've talked about in terms of overload, and specificity and so forth. And I know there's still a whole lot more for you to learn, but I just want you to start thinking about that. Take into mind as well the kinesiology slides that we talked about previously in terms of what that represents in trying to decide what's working, what muscles are working, what joints, what are the angles, and so forth. Welcome back. The next thing we have to look at is something called the transfer of training. So the question becomes, when you train someone, is there any transfer of that training that benefits somewhere else? A program of exercises designed to develop muscle strength also has been shown to improve muscular endurance at least moderately. Okay? But endurance training has little to no cross-training effect on strength. So strength does improve mildly endurance, but endurance does not improve strength. So as I said, maybe you start off with endurance training because it's early in the rehab, but at the end of the day, if the job at hand or the task that's required to do, that the patient's required to do, requires strength, then you have to move into strength training because the endurance training is not going to have any effect on their ability to gain strength. The other part is, or the unfortunate part is that for all this work that you put in, you can lose it all very, very quickly. So these adaptive changes in response to resistance training are transient unless training-induced improvements are regularly used or the individual participates in a maintenance program. This is where it sometimes gets tough. You have a patient who comes in, they've injured themselves. You realize the reason they have is because they're very weak in an area to do their job that they have to do. So you get rid of their pain, you put them on an exercise program, you get them nice and strong, they return back to work, everything's going great, and they stop working out. And a year later, they end up back in your office again because they're weak again, because they didn't continue the training. What happens is a reduction in muscle performance begins a week or two after the cessation of resistance exercise and will continue until the training effects are lost. The research shows that if you're stuck in bed, within 6 weeks, you've lost everything. So you lose it a little bit slower when you're actively moving around, but all the time put in, if the patient doesn't continue in the exercises, they will detrain and go right back to normal. So with this in mind, strength and endurance training are incorporated into daily activities as soon as possible. So back in the day, if you had like my shoulder surgery, I might be spending 3 or 4 days in the hospital in bed. They don't want that anymore. So although the shoulder might not have been doing much, they want me off my butt, walking around, moving, maybe doing exercises on my legs. In fact, I was doing aerobic exercise when I had my shoulder surgery done. My arm was in a sling, but I was walking on a treadmill or a stair climber, trying to keep my body moving because of this detraining that can occur that we don't want. So here in this table, just have a look at some of the things that happen with muscle function and adaptation. So we can, the muscle becomes larger. There's some controversy about whether or not we grow new muscle cells versus just the muscle cells we have getting larger. We also get fiber arrangement and length changing. We see an increase in certain fiber types, which we're going to be talking about shortly. The length tension relationship we'll talk about a bit later on, but it's about how much tension the muscle can build. Recruitment of motor units, how many motor units a muscle can use or can't use improves, and then the type of muscle contraction. So we look at the force output from greatest to least. So the most output is in eccentric contraction, then isometric, and concentric produces the least amount of force output. So it's something that we have to think about as well as changing the speed. So, like we said, muscle requires adequate sources of energy to contract, generate tension, and resist fatigue. We know that. It's metabolically active. It requires ATP to work. We have mitochondria that are doing that and so forth. The predominant fiber type found in the muscle and the adequacy of blood supply and the removal of waste products all affect the tension producing capacity of a muscle and its resistance to fatigue. So when the muscle is contracting, it requires chemicals in order to do so, but it also has metabolic waste byproducts from having that contraction. So we need to have a system by which the muscle gets everything that it needs as much as possible, but also that it removes all the things that are left over from the work that's being done. So what is fatigue? Because the reality is, you might say to yourself, if the mitochondria can continue using exercise to produce ATP, why would a muscle ever get tired? So muscle or local fatigue is a diminished response of the muscle to a repeated stimulus. So if I ask a muscle to contract over and over and over and over and over again, eventually it'll just start to weaken and it won't be able to produce the tension. Progressive decrement in the amplitude of motor unit potentials is what happens. So where the nervous system isn't speaking to as many muscle fibers anymore because they're getting worn out. Acutely, this response to exercise is normal and reversible. Therefore, it is a temporary state of exhaustion, which results in a decrease in muscle strength. So if you're training properly and you're doing strength training, yes, you get down to those last couple of repetitions, they become extremely difficult, somewhat painful, and then the muscle becomes exhausted. In a very short period of time, within the first minute or so, those muscles completely recuperate and are ready to go again. So when we look here on the right in this chart, we can see there are type 1, type 2, and type 3 fibers. And we look at the resistance to fatigue. I don't know if you guys remember these from the previous lectures. We've got fast twitch and slow twitch and so forth. Their capillary density is there and so forth. So they're aerobic with type 2B being anaerobic. So there are different fiber types and resistance to fatigue. Type 1 is your high resistance to fatigue, whereas type 2 is your anaerobic fast twitch sprinting fibers. They have low resistance to fatigue, low capillary density. They rely entirely on anaerobic metabolism, and they tire out very, very quickly. So, fast fibers, white, most common. They're called because they reach peak tension the fastest. They're large in diameter with densely packed myofibrils, large glycogen reserves or stores, and few mitochondria because they tend to work anaerobically. Due to the high amount of fibrils, these produce powerful contractions, but they don't last very long. They're powerful, but very short term. There's not enough mitochondria to maintain it. It's all anaerobic, and they just can't hold on. These are known as type 2 fibers or phasic fibers. They're further subdivided into type 2A and type 2B. Type 2B are completely anaerobic, do not use any oxygen at all in terms of the creation of ATP, and fatigue more quickly than type 2A because type 2A utilizes a small amount of aerobic metabolism. So ultimately, 2B is a fast fiber. It's a fast fiber that is completely anaerobic and fatigues very quickly, whereas 2A is still a fast fiber, fast contraction. It fatigues quickly as well, but not as quickly as 2B. Slow fibers are red, not white. They're half the diameter of fast and take 3 times as long to achieve peak tension. Very slow to achieve peak tension, but when they get there, they can hold that tension for a considerably longer time as compared to the fast twitched fibers. So these guys can contract for extended periods. They're surrounded by an extensive work of capillaries as we compare them to the fast fibers. And because they rely entirely or mostly on oxygen metabolism, they contain a lot of myoglobin, which is attracted to oxygen. So therefore they have substantial oxygen reserves, and these guys use aerobic metabolism more than 2A. So I talked about fatigue. So if we look at the cardiopulmonary, if the cardiopulmonary system's not working well, lung problems or heart problems, the whole body diminishes its response entirely. It's a result of prolonged physical activity can cause this. So if we're doing something for a very long extended period of time, this can cause fatigue in the whole body. And this cardiopulmonary is related to the patient's ability to utilize oxygen. We measure that by doing what's called a VO2 max test. So we start to look at how much VO2 max does the patient use. So it's represented in a particular way. The higher the number, the more in shape someone is as compared to someone else. So we want a higher VO2 max if we're actually going to get someone into better shape to train. Recovery from exercise. One of the key things you need to do, because resistance training does cause fatigue, is that you must allow within your prescription time to recover. So you have to have periods of time where the muscle can recover. And so the body must be given time to restore itself to a state that existed prior to the exhausted state which the training caused. For the muscle to return to 90 to 95% of pre-exercise capacity usually takes 3 to 4 minutes, with the greatest proportion of recovery occurring in the first minute. When I train resistance training in the gym, people always accuse me of looking at my watch all the time, and the reason I'm doing that is because I try to do my next set of repetitions 1 minute after the last, which I know gives me the most amount of recovery, because remember, stress equals adaptation. I want to exhaust the muscle in order to gain more strength or more power, or more endurance for that matter. So age, what happens? Well, early childhood and pre-adolescence, basically strength is related to the development of muscle mass. So obviously as we get older, our muscle mass increases and it becomes better. In the early childhood, then, training-induced strength gains occur primarily as a result of neuromuscular adaptation, not in muscle mass. So in young children, the conversation between the nervous system and the muscles becomes more efficient, therefore the child becomes stronger. But the child, prepubescent child, is not going to grow massive amounts of muscle mass as someone who is an adult or post-pubescent. Now, the thing is, if you're going to do strength training with children, you do not want heavy weights, because the fear is concern with injuries such as epiphyseal fractures or avulsions, meaning it slips. So a epiphyseal plate is very sensitive. You place a very strong stress on it, it could shift and do damage to it. Adolescence, basically due to hormonal changes, there's rapid acceleration in the development of muscle strength. So because muscle strength and size is influenced by testosterone, boys generally tend to have larger and faster development of muscles because we have a greater amount of testosterone. Women have testosterone as well, but to a lesser degree, so therefore there are some changes. There are women who have higher amounts than others, and these individuals can train much better. Muscle mass peaks before muscle strength and should be low intensity resistance training if you want to move these people through. Young and middle-aged, usually strength reaches a maximal level in women in the second decade and men in the third. So you're gonna reach your maximums there. Although I could see this research changing a bit, because my thought is quite possibly that through sedentary people may have had some sort of influence on it. But what happens is strength declines 1% per year and 8% per decade as we move through. These 1% are minor until you get to about 50. After the age of 50, you start to see more declines. But again, I'd like this compared to someone who's keeping themselves active through most of their life after that. Muscle improvement with resistance training several times per week is high in this group. So you're going to get big changes when you train this group. Late adulthood, well, the decline in tension generating capacity accelerates to approximately 15 to 20% per decade in the 60s and 70s, and afterwards 30% per decade. So we have a high level activity will significantly slow. If they're doing a lot of physical activity, you're likely going to have a great effect on this 15 to 20%, and likely knock it down to maybe 10% or lower, which is exactly what you're after. In fact, a lot of the research is now showing elderly people absolutely must do resistance training to maintain independence. We also see a decline in speed of contraction, muscle endurance, and the ability to recover from muscular fatigue as we get older. So when we start someone on a training regime, you see rapid changes in strength very early on in the training. This rapid increase in strength is not due to the muscle itself. It's still starting to grow. The initial rapid gain in strength is attributed to neural responses, not adaptive changes in the muscle. Also related to motor learning and improved coordination. So they get better at what you're asking them to do, and they become more coordinated and more efficient at it. But generally speaking, the adaptations you see early in strength are due to an increased recruitment in the number of motor units firing. So let's go back to the motor units firing, because I haven't spent a lot of time at this. A motor unit is a motor neuron and the muscle that neuron innervates. A motor neuron and the muscle that nerve innervates. Imagine, if you will, and I said we know the sarcomere, it can run as long as 30 centimeters down a quad. You have thousands of those fibers in there. Every single sarcomere is innervated by a branch of the motor neuron, and that is a motor unit. If I want to lift 5 pounds of that 1,000 fibers I have, 5 pounds may only require 10% of the motor units. If I have to push 50 pounds and I'm training, maybe I have to use 75% of motor units. But if I'm detrained and that's my max, I'm using 100% of motor units to do it. So it's safe to say that if someone is sedentary, there's a lot of quiet motor units that aren't being used. And when we place someone on an exercise prescription, we start increasing the conversation between those quiet motor units, and the nervous system starts utilizing them more. So maybe a sedentary person is only ever using 50% of the motor units, but with training, they start getting to that 100% very quickly in terms of that conversation, and they will see big changes in strength. So how does it adapt? Well, the first is hypertrophy. In other words, the tension-producing capacity of a muscle is directly related to the physiological cross-sectional area of the individual muscle fibers. Hypertrophy is an increase in the bulk or size of an individual muscle fiber caused by an increase in myofibrillar volume. In other words, everything gets thicker. So maybe it starts off the diameter of half a hair, and through training it becomes twice this thick as a hair. It appears to be the result of increase in protein with the actin-myosin synthesis and a decrease in protein degradation. This results of high volume, moderate resistance performed eccentrically is the best way to make muscles bigger. Let me repeat, high volume, moderate resistance performed eccentrically. Remember, eccentric contraction is contraction as the muscle lengthens. This is going to give you the greatest change in training. Hyperplasia is the increase in the number of muscle cells. There is sparse evidence, although someone in your class has argued with me a couple weeks ago to say that there's new stuff, and that's quite possible. But a small portion of the increase of muscle size that occurs with heavy resistance training can be the result of hyperplasia, which is the increase in number of muscle fibers. In the past, my understanding has been is you see this hyperplasia in those men and women who are lifting extreme amounts of weight to cause this. Again, my understanding is the normal person working out in the gym 3 or 4 times a week likely will not see hyperplasia. We also get vascular and metabolic adaptations. So a muscle's hypertrophy with high intensity, low volume training, capillary bed density increases, as well as a number of myofilaments per fiber. You may notice someone who has extremely large muscles who are a trainer, you're going to start to notice much larger veins on the surface. This is because metabolically, they're becoming more active. There's more byproduct to get rid of. So the cardiovascular system starts to make changes by placing more veins there as well, and larger veins to get the metabolites out of the area and going somewhere else. Connective tissue as well adapts to strength training. So the tensile strength of tendons and ligaments as well as bone increases with resistance. The changes in tendons likely occurs at the musculotendinous junction, and ligaments kind of occurring at the ligament bone attachment as well, getting thicker and stronger. Fundamentally, connective tissue strengthens, seems to thicken, and again, stress adaptation. Again, it's making the changes to adapt to the load or the work you're putting on it. And weight bearing and muscle strength increases the density of bone. And this is why the big movement is to train elderly people to try to get bone density back up again. Thanks for listening to this, this slide set. There's 2 more muscle resistant slide sets to go.